Assalamu alaikum wa rahmatullahi wa barakatuh. My colleagues in cardiology and electrophysiology. Today I'm going to discuss the accessory pathway and the AVRT. Accessory pathway is challenging in diagnosis, it's challenging in electrophysiology study and the induction of tachycardia, it's challenging in ablation. So let's start our lecture today to see what is accessory pathway. As we know, there is nodal conduction and extranodal conduction between atrium and the ventricle. Nodal conduction is AV node. When the impulse comes from atrium, go through AV node, then Hess-Purkinje system, left bundle and right bundle. Accessory pathway, the impulse will come to go through the accessory pathway and lead to ventricular pre-excitation. That's why we can appreciate in accessory pathway, we can see pre-excited QRS complex, delta wave, short BR interval, wide QRS complex. This, how can we see the pre-excited QRS complex? So, what is the difference between nodal conduction and extranodal conduction? Golden rule: when we have nodal conduction, it is decremental conduction. Number 2, concentric activation, septal activation. Meanwhile, extranodal conduction, accessory pathway, it is non-decremental conduction and eccentric activation. Historical milestones of accessory pathway. I want to highlight the amazing rule of Professor Dr. Kent. He was the first one who described the accessory pathway, the extranodal connection between atrium and the ventricle in 1913. When we confirmed it is not only nodal conduction, not only AV node that connect the atrium and the ventricle, but accessory pathway is there, and we have to find the relation between that accessory pathway and sudden onset palpitation, sudden cardiac death. Then many pioneers in electrophysiology confirmed the accessory pathway, and those are Dr. Wolff-Parkinson-White physicians in 1930 when they present the first paper documenting what is called pre-excitation in ECG. So they were the first team who described the pre-excitation during rest, when we can see delta wave, short BR interval, and since then we are telling Wolff-Parkinson-White syndrome, WBW, in resting ECG, and it was managed as medical treatment till 1983, till Dr. Melvin Chenman was the first one who used the catheter ablation using high energy direct current shocks. It was the first time to ablate the accessory pathway using catheter ablation. So, what is accessory pathway? Characters of accessory pathway. What are the common features? How can we classify accessory pathway? According to conduction, resting ECG, is it high risk or low risk accessory pathway? Where is the accessory pathway? During tachycardia, is it orthodromic, antidromic? Is it decremental or non-decremental? Is it only single accessory pathway or 2, 3 or more? Finally, typical and atypical accessory pathway. So let's have and try to find the answer to these following questions. It's 8 VIP question, golden rule when we assess accessory pathway. First question that you have to answer: what is the direction of conduction? Antegrade, retrograde, or bidirectional conduction? Number 2, ECG at rest. Can we see the evidence of pre-excitation or not? If concealed, no evidence of pre-excitation. Manifest, It's a clear evidence of pre-excitation. Number 3, is it low risk accessory pathway, no complication are expected, or it's a high risk accessory pathway? So we have to assess the risk of accessory pathway. Number 4, where is the accessory pathway, left or right, septal or lateral? Number 5, at tachycardia, is it wide complex tachycardia antidromic or narrow complex tachycardia orthodromic? Number 6, decremental pathway. Yes, we know 99% are non-decremental. However, there is exception, accessory pathway with decremental conduction. Number 7, usually it's a single accessory pathway, but occasionally it may be multiple accessory pathway. How can we confirm and reach the diagnosis of multiple accessory pathway? Finally, is it typical short atrioventricular accessory pathway, or it's atypical like nodovascular, nodoventricular Mahaim accessory pathway? So let's highlight some of these classification, starting with resting ECG. Can we see a clear evidence of manifest accessory pathway or not? What does it mean? At the left panel, we can appreciate accessory pathway with antegrade conduction. That's why we can see pre-excited QRS complex, delta wave, short BR interval. Meanwhile, on the right panel, there is an accessory pathway, but we can't see any evidence at the resting ECG because it's concealed the accessory pathway, no antegrade conduction, it's only retrograde. That's why no delta wave, no short BR interval. And this is the ECG. At the left side, we can appreciate manifest pre-excitation, great delta wave at V1 and in all leads. What does it mean? The accessory pathway is manifest. Accessory pathway has antegrade conduction. Meanwhile, on the right hand, it's a concealed pre-excitation. Looks as if normal ECG, no evidence of accessory pathway. And we know later when we assess the EB study, we found the accessory pathway but no antegrade conduction. Let's go to a common scenario, great golden rule, when we have a patient present with asymptomatic accessory pathway. We can see the accessory pathway at ECG. We have to know, is it high risk accessory pathway? So we have to be meticulous, go for urgent EB study, urgent ablation, or just it's a low risk accessory pathway, no harm, no worries, so we can just follow up. So we have to see if the patient is asymptomatic pre-excitation, is it high risk or low risk? How we know? Let's see this example. One of our patients present to our clinic, 20 years old male patient, has manifest pre-excitation, asymptomatic, no palpitation at all, no tachycardia at all. However, he came just for a checkup, and during checkup ECG showed manifest pre-excitation. So what do you think? What is the next step? Just to reassure the patient, as no evidence of palpitation, go for treadmill test or urgent ablation to ablate this accessory pathway, or we can start medical treatment in the form of sotalol. Golden rule, we have to see, is it high risk accessory pathway or low risk? So let's go for treadmill test, exercise test. And during exercise, we can differentiate high risk accessory pathway, which will conduct the impulse till reaching fast heart rate, or it's low risk accessory pathway, just conducting at a slow heart rate. And once the patient has tachycardia, it will not be able to conduct. And in our patient, once the patient starts exercise, What happened? Sudden loss of pre-excitation, back to normal resting ECG, no evidence of pre-excitation. So, golden rule, what is high risk and low risk accessory pathway, and how we can know? 3 steps. Ejection fraction in echo, it means if the patient has impaired ejection fraction, it's evidence of desynchronization and we have to ablate. Number 2, occupation. If the patient is working as a pilot, it's a high risk occupation and we have to go for ablation. Number 3, what about the accessory pathway during non-invasive and high invasive intervention? If the patient in non-invasive investigation showed intermittent loss of pre-excitation at Holter or treadmill test, like our example, it means it's a low risk. In EP study and invasive strategy, we have to assess the accessory pathway effective refractory period reaching 250 milliseconds or less, or shortest RR interval during AFib less than 250, multiple accessory pathway, induction of tachycardia. All of these confirm it's a high risk accessory pathway and we have to ablate. Where is the accessory pathway? When we want to classify the accessory pathway, AVRT, we should know where is the accessory pathway, and you have to imagine the AV annulus, the blue one tricuspid annulus, the red one mitral annulus, and this coronary sinus in posterior region. This is mid septum, and this in the anterior, and this is the anteroseptal or superior paraseptal region. So we have to classify, is it right accessory pathway or left accessory pathway? Is it posterior or anterior? Is it lateral or septal? According to this, we can classify our accessory pathway patients. And the first one who described a VIB algorithm was Aruda in 4 steps, and classify all accessory pathway locations: left lateral accessory pathway, epicardial, subepicardial accessory pathway, septal accessory pathway, posteroseptal, mid-anteroseptal, and finally right free wall accessory pathway. Let's go to step number 1 and see how Aruda classify accessory pathway locations. Step number 1, left free wall. How we know? Tall R in V1, R more than S in V1, or negative delta wave in lead 1 and the EVL. Here we can appreciate clear evidence of left lateral accessory pathway, and transeptal puncture is indicated. Again, left antero, left lateral accessory pathway on the right panel, left posterolateral and posterior accessory pathway. We can appreciate in the right panel R wave more than S in V1, negative delta wave in 1 and the AVL, and we can see negative delta wave in 3 and the AVF. It's left posterolateral. Step number 2, is it epicardial accessory pathway, subepicardial, mid MCV, or great vessel? Let's see. We can appreciate in lead 2 great negative, manifest negative delta wave in lead 2 start earlier than other delta wave. Here we can appreciate a clear epicardial accessory pathway in middle cardiac vein and in coronary sinus itself. Look at lead 2. This is the key. Number 3, step 3, septal accessory pathway. After exclusion of left lateral accessory pathway, exclusion of epicardial, look at V1. It's a negative delta wave in V1, and the transition usually it's early V2, V3. And you have to look at the inferior leads. If you find positive delta wave in 2-3 AVF, it looks anteroseptal accessory pathway. If it's a negative delta wave 2-3 AVF, looks posteroseptal accessory pathway. Here we can appreciate a clear posteroseptal accessory pathway, and this is anteroseptal midseptal accessory pathway, and this is a challenging pathway in which you have to be meticulous to avoid AV nodal fast pathway ablation, to avoid unnecessary complete heart block. And this is an example of anteroseptal accessory pathway. This is the ablation catheter in RAO, LAO. How close we are from the AV node. Just take care, avoid his deflection. Be careful and ablate the anteroseptal accessory pathway. Last step, step 4, right free wall step, in which we can appreciate positive delta wave in V1, late transition maybe V4, and assess inferior leads to know if it's a positive. It means anterolateral right side accessory pathway. If it's a negative, it's a posterolateral right side accessory pathway. And this is an example, a clear example of right anterolateral accessory pathway. How we know? It is clear positive delta in V1, late transition V3, V4, and positive delta in inferior leads. So we are dealing with anterolateral right-sided accessory pathway, and here where we did ablation, it was successful ablation using ablation catheter. Go to the right side tricuspid annulus, right free wall, successful ablation. Now let's go to the next golden rule, accessory pathway and tachycardia. How does it present and participate in tachycardia? We have 3 scenarios. First clinical scenario is orthodromic atrioventricular reciprocating tachycardia, and it is narrow complex tachycardia. You have to differentiate from other types of narrow complex tachycardia and the SVT. Second scenario, antidromic tachycardia, and it is wide complex tachycardia. You should differentiate from other wide complex tachycardia and VT. Finally, pre-excited AFib, the most critical and horrible accessory pathway mediated tachycardia. Let's see the difference between orthodromic and antidromic. In orthodromic tachycardia, it's a narrow complex. Impulse go down antegrade through the AV node, then retrograde through the accessory pathway and continue the re-entry. Meanwhile, on the right side, it's antidromic tachycardia, in which the impulse will go antegrade to the ventricle through the accessory pathway, retrograde AV node, and it is wide complex tachycardia. Here we can see the narrow complex tachycardia at the left side of orthodromic tachycardia. Wide complex tachycardia on the right panel, it is antidromic tachycardia. And to understand and illustrate more and more, in orthodromic tachycardia, it is narrow complex, as we see in ECG. Impulse will go down antegrade AV node, retrograde accessory pathway back to atria. That's why it's a narrow complex. You should differentiate other SVTs like AVRT and atrial tach. Meanwhile, in antidromic tachycardia, it's a different story. The impulse will go down through the accessory pathway, retrograde AV node. In ECG, it's white complex tachycardia. You have to discriminate from VT and SVT with aberrancy. Finally, the most critical accessory pathway tachycardia, pre-excited AFib, in which the impulse coming from pulmonary vein triggers in atrium go down through both accessory pathway and the AV node. Meanwhile, we know the accessory pathway conduct fast, so we will see short RR interval. Also, there is variable conduction and diffusion between AV node and the accessory pathway. So in ECG, we may appreciate wide complex and wider complex after this because of fusion. Now, let's go to the next golden rule to know is it single or multiple accessory pathway. It's a simple golden rule. When we find one of the following, we can expect it is not only single, it may be 2, 3, 4 multiple accessory pathway, like different B-wave morphology during orthodromic tachycardia, a change in RB interval during 2 or 3 accessory pathway mediated tachycardia, AFib with 2 pre-excitation pattern. It is not only one, sudden and direct switch from narrow complex to wide complex, orthodromic to antidromic. Finally, discrepancy between V insertion in antidromic tachycardia, atrial insertion in orthodromic tachycardia. Here it's an example of a patient has 2 accessory pathway. In the left side, we can appreciate anteroseptal accessory pathway and RB of about 70 milliseconds. Then sudden become wide complex tachycardia. V1 show typical right bundle morphology. In this, the patient has right lateral accessory pathway and we can appreciate RB interval become longer, more than 100 milliseconds. So this patient has 2 accessory pathway, anteroseptal, then right lateral accessory pathway with different and a change in RB interval. Here we can appreciate a change in atrial activation sequence. This patient has 2 accessory pathway. First one was left lateral accessory pathway with earliest atrial activation at the right arrow, the red arrow at distal CS. Then sudden a change in atrial activation sequence. The blue arrow show earliest A at CS 9 10. It's a septal accessory pathway. So alternating between conduction through left lateral and septal accessory pathway. In this, we can appreciate another patient with 2 accessory pathway during tachycardia. Looks positive delta wave in V1, looks lateral right side accessory pathway. Then we started ventricular pacing. What we can see, earliest atrial activation at distal CS 1 2. So this patient has right lateral and left lateral accessory pathway. Amazing, many criteria. Using it, we can reach diagnosis of multiple accessory pathway. Let's go to a little bit advanced golden rule, how we know the multiple accessory pathway. It's very important to diagnose during ECG, resting ECG, ECG during tachycardia, and for sure during the EEB study to confirm diagnosis and to know that you will ablate 1, 2 or 3 or more accessory pathway. So how can we know during tachycardia orthodromic, antidromic, or during pre-excited resting sinus ECG. Finally, during ventricular pacing, we should have answers. So let's go to golden rule. How can we diagnose multiple accessory pathway during tachycardia? Orthodromic tachycardia, you will find a change in VA interval using 2 or 3 multiple accessory pathway, or change in atrial activation sequence, maybe distal or proximal CS. But during antidromic tachycardia, you will find a change in VH interval without any change in tachycardia cycle length. It means it used multiple accessory pathway, and you may surprise when you find tachycardia cycle length during antidromic is slower than tachycardia cycle length during orthodromic. Confirm clear evidence of multiple accessory pathway. What about the pre-excited sinus ECG? How we know multiple accessory pathway? It change in delta wave during atrial pacing or during using multiple anti-arrhythmic drugs. But in ventricular pacing, you should appreciate different atrial activation sequence in ventricular pacing, or mismatch between antegrade conduction, ventricular insertion, retrograde conduction, atrial insertion, to confirm multiple accessory pathway when you base from ventricle. And this is the illustration and the summary from Braunwald textbook to know all criteria to confirm multiple accessory pathway, especially during orthodromic and antidromic. Finally, when you assess accessory pathway, golden rule, you should know, is it typical accessory pathway or atypical accessory pathway? Typical, like this red accessory pathway number 7. It is short atrioventricular connection connecting atrium and the base of the ventricle. This is the typical, and usually it is very short, maybe left or right. It is non-decremental conduction. A typical accessory pathway is different story. It may be long atrioventricular or atriofascicular like Mahaim, the most common type of atypical accessory pathway. Also, it may be nodofascicular, nodoventricular, the green one, or finally, it may be fasciculoventricular accessory pathway. And a typical accessory pathway, different story, different connection and conduction. Golden rule, how can we unmask the accessory pathway? Pre-excitation at resting ECG. When the patient presents with manifest pre-excitation, no doubt about accessory pathway, but sometimes it is subtle, it is mild pre-excitation. So how can we know and assess and cover, unmask the pre-excitation? Golden rule, you should know degree of ventricular pre-excitation depend on decrease the nodal conduction using any drug like adenosine beta blocker or calcium channel blocker, or increase the accessory pathway conduction to increase the pre-excitation at ECG. How? Through incremental fast atrial pacing, or giving atrial excess stimulus at shorter coupling interval, or pacing very close to the site of the accessory pathway. Golden rule, you have to know, because you should unmask the pre-excitation. And to understand this issue, you should imagine in accessory pathway, the impulse come from atrium, go through the AV node and accessory pathway. The more accessory pathway conduction, the more pre-excitation. So if you increase the accessory pathway conduction or decrease the AV node conduction, it will be manifest accessory pathway pre-excitation at ECG. And you have to imagine it is like a race and competition between accessory pathway, which is fasting conducting pathway, and the AV node, which is the slowly conducting pathway. When you give the chance to accessory pathway to conduct more, it's more pre-excitation, and when the AV node conduct less and less, it's more pre-excitation. And in ECG, how can we unmask the pre-excitation? It's 3 steps. Number 1, give drugs like adenosine, beta blocker, or calcium channel blocker. One of these drugs will decrease the AV node conduction here, the ECG, subtle pre-excitation. Give adenosine, block the AV node. Surprisingly, it's a manifest pre-excitation. You block the AV node, you give a chance to the accessory pathway to conduct more and more, and clear evidence of pre-excitation. What else? We can base near and close to the accessory pathway. Here we can appreciate left lateral accessory pathway. Start atrial basing from high right atrium. There is a subtle pre-excitation. Then we give SC2 at coupling interval 200 milliseconds. Subtle, mild pre-excitation. Now let's base from distal CS. You are very close to the lateral accessory pathway, starting S1, then SC2 at 200 milliseconds. You are very close to the accessory pathway. What happened? Manifest great pre-excitation. Finally, let's give SC2 atrial extra stimulus at short coupling interval. It will stress the accessory pathway to conduct more and to win and gain the race. However, the AV node will conduct less and less, so we can see more pre-excitation. Let's give SC2 at 440. Start to conduct more through the accessory pathway, pre-excitation. Then now let's give SC2 shorter coupling interval 350. We can see more pre-excitation, evidence of delta wave, and we can appreciate HV interval become negative. Now let's give SC2 at shorter coupling interval, stress more and more the accessory pathway at 190 milliseconds, the coupling interval. What happened? Manifest pre-excitation. HV interval become more negative value. Why? Because conduction now through the accessory pathway, mainly even retrograde conduction AV node. So, golden rule. What is the use of adenosine in accessory pathway? We have 3 clinical scenarios where should we use the adenosine. First one, unmask subtle pre-excitation. Number 2, differentiate the typical AV accessory pathway from another rare atypical accessory pathway called fasciculo-ventricular accessory pathway. Finally, terminate SVT and reach the diagnosis. First clinical scenario, give adenosine to unmask accessory pathway. We know about this and the rule of adenosine. Second rule, when you give adenosine in typical accessory pathway, you will create more pre-excitation, and here we can see amplitude of delta wave increase dramatically after adenosine. All accessory pathway will present manifest pre-excitation and increase in delta wave amplitude dramatically after adenosine, except fasciculo-ventricular accessory pathway, insignificant or no change in delta wave amplitude. Third scenario, and this is the example of fasciculo-ventricular accessory pathway, subtle pre-excitation. We give adenosine, still subtle pre-excitation. A change in amplitude is of no significance. Last scenario, which we use adenosine. In all types of SVT, we should use adenosine to terminate tachycardia. Confirm diagnosis, your differential diagnosis. For example, when you give adenosine in AVRT or AVRT, sudden termination. When you give adenosine in flutter or persistent atrial tach, it will be atrial tach will persist with high grade AV block, maybe 3 to 1, 4 to 1, 5 to 1. But if you give adenosine in sinus tachycardia, it will be gradual slowing and re-acceleration. And this is the examples, and I want to highlight the role of IV adenosine in orthodromic tachycardia, in which it's a short RB tachycardia, RB interval more than 70 milliseconds. Then on adenosine, the response is sudden termination back to sinus rhythm with manifest pre-excitation. So adenosine is useful to terminate orthodromic tachycardia and for sure confirm diagnosis. Now let's go to EEB study. And as we agreed before, when we go for EEB study, we should know all the history of the patient, tachycardia, sudden onset, how does it terminate. We should know all medical treatment about the patient, and it's advisable to stop all antiarrhythmic drugs 5 days before EEB study. And as we know, it's 4 pillars, 4 stages during EEB study. If you want to go for appropriate assessment of AVRT, we have 4 stages. Stage number 1, resting study, assess manifest conduction or concealed, assess your patient very well, ACG, AGM analysis. Stage number 2, the basic routine EEB study, antegrade conduction, retrograde conduction to assess the accessory pathway. Number 3, induce tachycardia, analyze the tachycardia onset termination, VA relationship. Finally, advanced special maneuver to assess is it septal accessory pathway and differentiate from AVNRT. This is the 4 steps. Start with stage number 1, where we have a patient, resting ECG, no pre-excitation. We have to use all mapping diagnostic catheter, RVCS, HIS, high right atrium. Then you have to see the ACG, analyze, no pre-excitation. Then see the RV, high right atrium, channels, HIS and the CS channels. And you have to assess AHV. Also you have to measure the intervals, BA interval, HV interval. And conceal the pre-excitation, conceal the accessory pathway, it will be normal. However, when we have a baseline pre-excitation, it means the accessory pathway has antegrade conduction, in which we can see the ACG during rest with delta wave, short BR interval, wide QRS complex. And we have to assess the interval between the onset of delta wave at ECG and the H, and we will find the HV interval is less than the normal, less than 35 milliseconds. Why? Because the ventricle is pre-excited mainly through the accessory pathway. It is not dependent on nodal conduction. That's why the HV interval will be short, and the more pre-excitation, the shorter HV interval. The more and the more pre-excitation, H and V may be in parallel activation. Finally, HV interval may be negative, and ventricular pre-excitation will be dependent only on accessory pathway. This is at rest. And to understand more, we have to discriminate the nodal conduction and the extranodal conduction. At right side, there is accessory pathway, And as we agreed before, accessory pathway conduction mean it's a non-decremental conduction. It is eccentric conduction if it's a lateral accessory pathway. At the left side, the nodal conduction, AV node, it means the decremental conduction and the concentric activation, septal activation ahead from the lateral. Okay, so now let's start the basic routine AB study, in which we will use our V catheter, HIS, CS, high right atrium catheters. Then we will start basing, atrial basing, to assess antegrade conduction. Then ventricular basing to assess retrograde conduction. Then to discriminate, is it extranodal accessory pathway conduction or it is nodal conduction. Golden rule: when we do the EB study, we confirm the presence of extranodal conduction, accessory pathway. In antegrade conduction, it is non-decremental conduction, fixed AH, AV time. QRS complex will be wide, pre-excited, delta wave, confirm antegrade conduction. Meanwhile, in retrograde conduction, during ventricular basing, it is non-decremental conduction, fixed VA interval, and it's eccentric atrial activation sequence in case of lateral accessory pathway, and it may be concentric atrial activation, septal activation if it is septal accessory pathway, and you have to discriminate from the septal accessory pathway and the AVRT in the following. Now let's start basic AB study in case of AVRT, ventricular burst basing and the extrastimulus basing to assess retrograde conduction, atrial burst basing, extrastimular basing to assess antegrade conduction, and to know how accessory pathway behave. Okay, in ventricular burst basing, golden rule: you have to see the presence of retrograde conduction through the accessory pathway. If no retrograde conduction, you can exclude the presence of accessory pathway. Is it concentric or eccentric retrograde atrial activation sequence, non-decremental conduction, and finally when accessory pathway will block. And this is an example. At the left side we can appreciate concentric activation, nodal conduction, and the earliest activation at CS 910. Meanwhile, on the right side, a clear evidence of accessory pathway, left lateral earliest activation, CS1 and 2, and no evidence of decrementation. And here is the illustration of the accessory pathway. The blue arrow, we can see earliest activation, CS1, 2, and CS1, 2 is activated earlier and ahead from CS 910. And this is an example where we can appreciate ventricular basing to see and discriminate, is it nodal conduction or extranodal conduction, is it septal accessory pathway or left lateral accessory pathway. Next, ventricular extrastimulus basing, what we see and assess in accessory pathway conduction. This how we give ventricular extrastimulus. As we know, we give a train of S1 at, for example, 600 milliseconds, then give SC2 atrial ventricular extrastimulus, short coupling interval. This example, then we have to assess what is the response. So let's see golden rule when we give ventricular extrastimulus in case of accessory pathway. presence of retrograde conduction, because absent of conduction exclude accessory pathway. And is it concentric or eccentric? Atrial activation sequence. And from this we can localize the accessory pathway and know where the accessory pathway locates. And for sure it's a non-decremental retrograde conduction, fixed VA interval, and we have to assess the retrograde accessory pathway ERB. And this is the mitral annulus, tricuspid annulus. It is the AV connection, and from this we can imagine where is the accessory pathway, left or right, septal or lateral, anterior near the his, posterior near the coronary sinus. And from the earliest atrial activation we can know, for example, if the earliest atrial activation CS12, it is left lateral. High right atrium, it is right lateral. At his, it is anteroseptal accessory pathway. CS9 10, posteroseptal accessory pathway. And these are simple examples where we assess the rule of giving ventricular extra stimulus and see the earliest retrograde A. This an example of right side accessory pathway. We can appreciate SC2 earliest retrograde A at high right atrium channel, and here we give SC2 the earliest distal CS1 and 2 left lateral accessory pathway. Here give SC2 the earliest A at his, it is anteroseptal accessory pathway, and no more his deflection. Finally, this is posteroseptal accessory pathway, earliest A at posterior or proximal coronary sinus, and we have to discriminate from nodal conduction. So if the patient has eccentric atrial activation sequence, know about accessory pathway. But if it's a concentric atrial activation, it may be accessory pathway, septal, or it may be AVRT. And the nodal conduction, the main difference is decrementation. Accessory pathway, non-decremental. In nodal conduction, it is decremental. However, we have to use advanced basing maneuver. Now let's go to ventricular extra stimulus, and you see how can we induce the tachycardia. So let's give ventricular extra stimulus. Retrograde conduction may be fusion between nodal and the accessory pathway, giving ventricular extra stimulus at shorter coupling interval to stress the accessory pathway, more conduction through the accessory pathway. Then give at shorter coupling interval, we reach the ERB of the accessory pathway, refractoriness, no more conduction, retrograde conduction AV node, and antegrade accessory pathway, initiation of antidromic tachycardia. And this is of an example where we give a train of S1, then S2 ventricular extra stimulus at 350. We can appreciate retrograde conduction and we can see VA. Then after a while we stress the accessory pathway more and give shorter coupling interval 330, and now the conduction come from the AV node to left lateral accessory pathway. How we know? The earliest A at distal CS1 and 2. Now we stress more and we reach the ERB of accessory pathway, back to the AV node, then initiation of antidromic tachycardia, retrograde AV node, antegrade accessory pathway, and it is wide complex tachycardia. And here how we can see the ventricular extra stimulus and how it may initiate the tachycardia. Now let's go to the next atrial burst pacing in accessory pathway. Let's go for atrial pacing. We will give a train of S1 from the high right atrium and give S2 at shorter coupling interval and see how accessory pathway behave. Golden rule when you assess the antegrade conduction giving atrial extra stimulus, you have to assess the pre-excited QRS complex accessory pathway has antegrade conduction. HV interval will be short. Non-decremental accessory pathway conduction, no AH prolongation, no AH jump. Then initiation of tachycardia if we reach block in accessory pathway. And finally you can assess the block of accessory pathway or the antegrade Wenckebach cycle length if it is nodal conduction. Here atrial burst pacing, manifest pre-excitation, then the antegrade conduction of accessory pathway block, no more pre-excitation, then antegrade conduction AV node retrograde accessory pathway and the initiation of orthodromic tachycardia, a clear evidence of the accessory pathway antegrade conduction. Let's go to the last basic AB maneuver, atrial extra stimulus, in which we will give a train of S1 from high right atrium, then give S2 to assess pre-excited QRS complex, short HV interval, non-decremental accessory pathway antegrade conduction, initiation of tachycardia as S2 will block the accessory pathway when it reaches the refractoriness and the sudden loss of pre-excitation, initiation of orthodromic tachycardia. Also you can assess AV node ERB and accessory pathway ERB. Not only this, you can assess how high risk the accessory pathway is, risk stratification that we mentioned in asymptomatic. So let's assess the antegrade accessory pathway ERB. If it's 250 or less, it is extremely high risk accessory pathway and you have to ablate even it is asymptomatic. And when you give atrial extra stimulus, you should know it is a competition between accessory pathway, which is fast conducting pathway, AV node, which is slowly conducting pathway. The shorter coupling interval, atrial extra stimulus, the more stress on accessory pathway, the more conduction through accessory pathway, more pre-excitation. So let's give a train of S1 atrial pacing, then give atrial extra stimulus, and we can appreciate more pre-excitation. Delta wave come earlier and the H come late. Then we can see HV interval become short and short, then simultaneous activation H and V. Why? Because more conduction through accessory pathway, ventricular pre-excitation dependent on accessory pathway. So how does the orthodromic tachycardia initiate? Golden rule, you have to know the competition between accessory pathway and the AV node, then stress the accessory pathway more and more with fast atrial pacing or short coupling interval, atrial extra stimulus, HV interval, short, then negative. Then you will block the antegrade conduction of accessory pathway, which ERB, initiation of orthodromic tachycardia, antegrade conduction AV node, retrograde accessory pathway. Here we can appreciate giving atrial extra stimulus 440. There is evidence of pre-excitation and H activation, and the HV interval is short. Let's give S2 on shorter coupling interval, HV interval become simultaneous activation, even come ahead. So HV interval become negative, then become completely HV interval negative, antegrade conduction accessory pathway, then retrograde His and AV node. When we give SC2 at coupling interval 190, then initiation of tachycardia. Here we can appreciate pre-excitation, then give SC2, sudden loss of His at ECG, lead 1 to AVF, and initiation of tachycardia, narrow complex tachycardia, RB more than 90 millisecond and VA more than 70 millisecond, and induction of tachycardia with earliest retrograde atrial activation CS12. It is confirmed to have orthodromic tachycardia using left lateral accessory pathway, and this is an example when we give atrial extra stimulus and sudden onset orthodromic reciprocating tachycardia. However, this example is nodal conduction and no evidence of accessory pathway, as we give atrial extra stimulus, sudden AH jump, then decrementation. Now let's go to tachycardia, induction of orthodromic reciprocating tachycardia, stage number 3 in EB study. And we have to know there is 3 common tachycardia that we should discriminate from each other. Is it AVNRT, orthodromic accessory pathway, AVRT, or it is atrial tachycardia, or all of them are now complex tachycardia? And to assess the SCVT very well and know is it AVRT or not, you have to answer the following. What is the relation between VA conduction, then atrial activation sequence? Is it concentric or eccentric? Number 3, VA interval, long or short? RB. Termination of tachycardia and onset of tachycardia, termination with A or V. Is there any wobble of tachycardia? What about intervals change? H interval change first, or A interval change? Finally, VA time increase with ipsilateral bundle branch block. Golden rule in AVRT: when you have a tachycardia, you should assess the following 6 points. VA relationship, it is 1-to-1 conduction in 99 cases of accessory pathway mediated tachycardia, 1-to-1, no evidence of dissociation at all, except one rare condition called the nodovascular. Number 2, atrial activation sequence, eccentric in lateral accessory pathway, concentric septal accessory pathway, and you have to discriminate from the AVNRT. Number 3, VA interval. All accessory pathway tachycardia are short RB with VA interval more than 70 millisecond, except one rare condition, BJRT, atypical accessory pathway with long RB tachycardia in pediatric. Number 4, how does we initiate AVRT? By atrial extra stimulus, sudden loss of accessory pathway, block the accessory pathway conduction, then initiation of tachycardia, antegrade AV node, retrograde accessory pathway, termination of tachycardia may be A or V. Wobble of tachycardia, usually AVRT is His dependent. H interval change predict AA interval change. Finally, Commel's sign, in which we will find increase in VA time when the patient has accessory pathway and developed ipsilateral bundle branch block. For example, patient with left lateral accessory pathway developed left bundle branch block, we will find sudden increase in VA time more than 30 milliseconds. Confirm the presence of accessory pathway. And to understand all of this, we should imagine that in case of orthodromic tachycardia, we have a re-entry. Antegrade from atrium to ventricle is nodal through the AV node. Retrograde conduction ventricle to atrium is accessory pathway. And the tachycardia involve the atrium, AV node, ventricle, and accessory pathway. And dissociation between V and A is impossible because the re-entry circuit involves the V. So we have to know it is one-to-one conduction in all types of accessory pathway mediated tachycardia. It is one-to-one conduction. V to A is one-to-one, like atrial tach and the AVNRT. However, there is only one rare conduction, which is nodofascicular. You may find the V more than A, like junctional tachycardia and the AVNRT with upper common pathway block, and you have to discriminate. And we know about this because in atrial tach it may be dissociation A more than V. In AVNRT usually one-to-one conduction. However, atrium and ventricle are not necessary structures in AVNRT, so in case of common pathway block it may be dissociation. But in AVRT and accessory pathway, it's a different story. The AVRT circuit include ventricle, so VA dissociation is extremely uncommon because it is one-to-one conduction. Dissociation is impossible. And here we induce the AVRT by ventricular basing. We can appreciate on the right side AVRT using left lateral accessory pathway. Conduction is one-to-one conduction. This is golden rule in all AVRT. However, there is a rare exception, the nodofascicular connection between AV node and right bundle or ventricle, and there is VA dissociation, V as we can appreciate in this example more than A. Golden rule is spontaneous or induced AV block during continuation of SCVT. It means AVRT is excluded 100% because the general rule it is one-to-one conduction and it's impossible to have dissociation. So it is a golden rule. If there is dissociation, exclude AVRT. Let's go to the next golden rule. When we have a tachycardia, assess atrial activation sequence. Concentric may be AVNRT, AVRT using septal accessory pathway or atrial tach. Eccentric, AVRT using lateral accessory pathway and the atrial tach. And the AVNRT is impossible. And this is the patient on the left side, nodal conduction or septal accessory pathway. We will have concentric atrial activation. On the right side, left lateral accessory pathway, it is eccentric activation. And this is a case of left lateral accessory pathway, aorist atrial activation on the right side of tachycardia at CS 1 and 2, distal CS. What does it mean? It is eccentric atrial activation. It is AVRT using left lateral accessory pathway. However, in this case, we can appreciate retrograde conduction at His. So it is concentric atrial activation, and it is example of septal accessory pathway. Golden rule, eccentric atrial activation, it is accessory pathway. Concentric activation, you have to think about, is it septal accessory pathway or a case of AVNRT? And this is a case of atrial activation. We give extra stimulus and we induce the orthodromic tachycardia. And we can see it is 1-to-1 conduction, airless atrial activation, CS distal. So we are dealing with left lateral accessory pathway, which is completely different from the AVNRT. When we induce the AVNRT with atrial extra stimulus and the airless RCS 910, it is concentric activation with very short VA interval less than 70 milliseconds. Let's go to golden rule. Assess VA interval during SCVT. Is it short RB or long RB? And short RB tachycardia, it may be RB interval less than 70 milliseconds, the VA interval, or the VA interval more than 70 milliseconds. The other side, long RB tachycardia, RB interval more than BR interval. And this is the golden rule to classify all types of SCVT, to know all types of short RB and long RB tachycardia. And I want to highlight, in AVRT, it is short RB tachycardia with VA interval more than 70 milliseconds, with one exception, the BGRT. Here we can appreciate the classic AGM of AVRT with septal VA interval more than 70 milliseconds. So it is short RB tachycardia, VA more than 70. So golden rule, when we have AVRT, it will present with short RB tachycardia with VA more than 70 milliseconds. Why? Because retrograde conduction through the accessory pathway, it will take more than 70 milliseconds to activate the ventricle, depolarization, retrograde accessory pathway, it takes time, then reach the atrium. So yes, it's a short RB, but the VA time, the retrograde conduction, will take more than 70 milliseconds. With one exception, BJRT, long RB tachycardia. Golden rule, if we have SCVT with VA interval less than 70 milliseconds, it's impossible to have AVRT. As we said, in retrograde conduction, AVNRT, it's a fast pathway, and we can appreciate atrium and the ventricle activated simultaneously. So VA interval less than 70 milliseconds and maybe in parallel. But in AVRT, the VA time is different because it takes more than 70 milliseconds for ventricular activation, accessory pathway retrograde conduction, then reach atrium. That's why VA time in AVRT should be more than 70 milliseconds. And this is example of AVRT. We can appreciate HA or VA time, it takes longer time. And this is the exception of BGRT, which is long RB tachycardia, the only exception of AVRT in which VA time is very long, and it is common scenario in pediatric. And we can assess the antegrade conduction through the AV node. Then retrograde conduction in BGRT is done through the slowly decremental conducting posturoseptal accessory pathway. That's why BGRT is long RB tachycardia. And if you have a case of BGRT, you should discriminate it from the other long RB tachycardia, a typical AVNRT fast slow, or atrial tachycardia, the most common scenario of long RB, or BGRT, the permanent junctional reciprocating tachycardia. Next point to assess AVRT, how does it terminate it? The general rule, any type of SCVT can terminate with V, no doubt about this. But what about A? Let's see. In AVNRT, it is AV nodal dependent, and if the patient has a block in slow pathway, the AVNRT may terminate with A that is not able to conduct to the ventricle because of AV nodal block, so it may terminate with A. In orthodromic tachycardia, in the middle panel, antegrade conduction AV node, retrograde accessory pathway. If AV node block, the tachycardia may terminate with A because it is AV nodal dependent. Block in AV node, the atrial impulse will not be able to go down antegrade. In atrial tachycardia, it's a different story. It is non-AV nodal dependent, and atrial focus will fire, atrial impulse will come, will go down through the AV node. So it's impossible to terminate atrial tachycardia with A because all atrial impulse will go down through the AV node. It is non-AV nodal dependent, and this is a case of AVRT terminated with A. It happens. Then back to sinus rhythm, we can appreciate the next sinus beat, pre-excited. So termination of tachycardia may be A, may be V, but golden rule, if you have SVT, termination with tachycardia, the tachycardia terminated with A, atrial tachycardia is excluded 100%. What about initiation of tachycardia? We know about AVNRT, initiate with AH jump. Atrial tach with different B wave morphology from atrial focus from anywhere left or right atrium. However, the AVRT has two pathway, accessory pathway and the AV node. And if you have atrial extra stimulus, it will conduct through the accessory pathway, ventricular pre-excitation. If you deliver earlier atrial extra stimulus, it will block in accessory pathway, reach the refractoriness, then antegrade conduction AV node, retrograde accessory pathway, initiation of tachycardia. Here we can appreciate atrial pacing, pre-excitation in ECG, then sudden initiation of tachycardia, sudden loss of pre-excitation as the accessory pathway reach ERB, so sudden conduction through AV node, antegrade conduction, retrograde accessory pathway, initiation of AVRT, re-entry tachycardia because of reaching ERB of accessory pathway. Now let's go to the sixth point when you induce tachycardia of AVRT and assess the features of tachycardia. In this, in the right side we have narrow complex tachycardia, and VA interval is 100 milliseconds, so it is not a case of AVNRT. Tachycardia cycle length 305. On the left side, the patient developed white complex left bundle morphology. During this, the VA time increased to 120 milliseconds. The cycle length increased to 325. So we are dealing with a case of AVRT using left lateral accessory pathway. How we know? This is the AVRT re-entry, AV node antegrade, retrograde accessory pathway. Then sudden block in left bundle branch, so the impulse will go AV node, then take very long way, right bundle branch block, right bundle pathway, then ventricular activation, then cell to cell conduction, retrograde, reaching accessory pathway, the left lateral accessory pathway, atrium. So the VA time increased so much. Not only VA interval increased, but also the tachycardia cycle length increased. And this is the amazing concept of COMEL when we assess AVRT using left lateral accessory pathway, and the patient developed ipsilateral bundle branch block. In this case, left bundle branch block. What happened? Increase in VA time from 100 to 120, and we can appreciate in the right side the impulse go down to illustrate more about our previous case. and cycle length 300. Why? It came down from AV node and his Purkinje system left bundle and retrograde accessory pathway. Cycle length 300. On the left side, this patient developed left bundle branch block, become white complex, and the cycle increased dramatically to 325 because it took longer interval, longer pathway. It go down, right bundle, ventricular activation, cell-to-cell conduction, retrograde accessory pathway, VA time increase, tachycardia cycle length also increase. And this is the Professor Philip Comel who described this amazing notice when he tell, if we have a patient SCVT increase in VA interval more than 30 milliseconds when he developed ipsilateral bundle branch block, it means definitely accessory pathway in the same side of bundle branch block. This is the example of normal orthodromic AVRT. Second one, the middle panel AVRT, left lateral accessory pathway, and developed the right bundle branch block. What happened? Nothing. Same conduction, same VA interval and the cycle length. However, when he developed left bundle branch block, in case of left accessory pathway, VA time increased, cycle length increased as well. Golden rule in case of left accessory pathway, when the patient developed ipsilateral bundle branch block, in this case left-sided, we will find increase in VA interval more than 30 milliseconds, confirm the presence of ipsilateral accessory pathway. However, if he developed contralateral bundle branch block, VA time would be fixed. One more example, when the patient had left lateral accessory pathway and developed the right bundle branch block, what happened? VA interval 80 is still 80 and cycle length 330 and still the same cycle length when he developed right bundle branch block. Nothing happened. Okay, now let's go to golden rule. When there is wobble in tachycardia, the patient of SCVT has a spontaneous change in tachycardia cycle length. Let's see. If the patient has AVRT, it is AV nodal dependent, we will find HH interval change predict AA interval. Why? Because it is AV nodal. So this is the AVRT response, same as AV NRT. However, in atrial tachycardia, it is non-AV nodal dependent, non-HIS dependent. So AA interval will precede and predict HH interval, and this is a case of AVRT. We can appreciate wobble in cycle length and the tachycardia, and the HH interval precede AA interval. So it is an AVRT. Is it a case of atrial tach? Impossible, because HH precede AA interval and tachycardia terminated with A. Confirm it is not atrial tach. It may be AVRT or AVNRT. So let's go to the advanced basing maneuver to help us to discriminate between all types of SCVT, especially AVNRT and the AVRT using septal accessory pathway. Both of them develop narrow complex tachycardia with concentric atrial activation. So we have to use a special maneuver to discriminate and to confirm is it AVRT or not. And we have main four maneuvers: overdrive basing, asynchronous BVC, both of them to be used during tachycardia, differential RV basing, parahesian basing, to discriminate between all types of SVT. Now let's start with the most powerful diagnostic maneuver, the overdrive pacing. How much it's useful and important to tell much data. As we know, ventricular overdrive pacing in narrow complex tachycardia, we can classify to transition zone when we start the overdrive pacing during tachycardia, constant capture zone when we keep pacing with one-to-one conduction, return zone when we stop the overdrive pacing and see what happened post pacing zone. So what we can assess during AVRT if we have a case of accessory pathway mediated tachycardia and tachycardia is ongoing, we start ventricular overdrive pacing. In return zone, we can assess the post-pacing response, the post-pacing interval, corrected post-pacing interval minus tachycardia cycle length, stem to A minus VA, and the atrial resetting, is it early or late? So, golden rule, when we have a case of AVRT using septal accessory pathway and we started the ventricular overdrive pacing, we can appreciate the following return zone, the return pattern VA-V response, post-pacing interval minus tachycardia cycle length less than 115. It's very close to the re-entry circuit. Corrected BPI less than 110. Difference between stem to A and V to A time during tachycardia less than 85 millisecond. What about transition zone? We can appreciate an evidence of fusion, fused based morphology, because there is a fusion between the re-entry and accessory pathway. And finally, atrial resetting is very early in transition zone. VA relation is one-to-one conduction in 99%. So let's focus about the concept of ventricular overdrive pacing in AVRT. As we know, it is in orthodromic, it is a re-entry come orthodromic AV node, retrograde accessory pathway, re-entry is ongoing. So this is the tachycardia. Then let's start pacing from RV slightly faster, 10 to 40 millisecond, then the tachycardia cycle length. Then stop ventricular pacing, let tachycardia continue without any termination. And this is Professor Moradi who gave us a golden rule about post-pacing response in the return zone. AVRT will have VA-V response like AV in RT. However, in atrial tach, it's different. It's a VA-V response. And to understand why AVRT is VA response, let's see the re-entry orthodromic tachycardia where impulse come from atrium, AV node to ventricle, retrograde accessory pathway. And let's base from the RV. This is the RV catheter. We will start pacing to see. So when we start pacing, ventricular activation and retrograde conduction to the atrium through the accessory pathway. So this is V and this is A, and the retrograde conduction is accessory pathway. Okay, let's keep ventricular pacing and see what happened for the last ventricular based beat. This is the last ventricular V, retrograde conduction atrium, and this is the last atrial accelerated beat at atrium. After stopping the pacing, what will happen? This last A will go antegrade orthodromic conduction through the AV node to reach the V and ventricular activation. So the response VAV response. Why it is like this? Because it is AV nodal dependent. That's why in AVRT it's a VAV response. And this is Moradi maneuver who described the response in AVRT is VAV response. And we got it because this is the last based V, last accelerated A, and this one go antegrade through the AV node because of AV nodal dependent. And this is a case of orthodromic AVRT on the right side of AGM. On the left side we can appreciate ACG lead 1 to AVF V1 V5, and this is the ablation catheter at A, CS and RV catheter, and the patient has ongoing AVRT. We start ventricular overdrive pacing. This is the spike, ventricular activation and capture, and atrial acceleration. This is the last ventricular based beat, and this is the last atrial accelerated beat, then V. So the response is VAV response. It goes with, consistent with AVRT. No doubt about this. Next, golden rule in AVRT and the post-pacing interval. In case of AVRT, the post-pacing interval minus tachycardia cycle length less than 115. In AVNRT, it's more than 115. And to understand the concept of this, of AVRT, post-pacing interval is less than 115 because it's very close to the re-entry, and the entry is large that involve the ventricle. So this is the AVNRT, and when we start pacing we give extra stimulus and ventricular beat. It will come from the RV catheter, go very long trip, reach AVNRT and take one cycle, exit, back, very long trip to RV catheter. So the difference between the post-pacing interval minus cycle length, which does not involve the ventricle, it's very long in AVNRT, more than 115. In septal accessory pathway it's different because the re-entry is large and involve the ventricle. So when we pace from the RV, just it exit from the catheter and it will join the AVRT re-entry circuit and take one cycle that involve the ventricle, then exit, and shortly will go to RV. That's why the difference is very short. We are very close to the septal accessory pathway. However, in left lateral accessory pathway, it's a gray zone. So let's see the following three examples, starting with this example, septal accessory pathway, a case of AVRT. We can appreciate the earliest retrograde A at HIS and proximal CES. It's a septal accessory pathway. Difference between post-pacing interval and tachycardia cycle length about 70 milliseconds. So we are very close. We are dealing with AVRT using septal accessory pathway less than 115 milliseconds. Let's go to next example, a case of AVNRT. Difference between post-pacing interval tachycardia cycle length about 200 milliseconds. We are very far, and it's a long trip to reach the VNRT re-entry that not involve the ventricle. So it's more than 115 milliseconds. However, this is AVRT using left lateral accessory pathway, earliest A at CS 120. It's about 120, 130. So it's a gray zone of AVRT using left lateral accessory pathway. Let's go to next golden rule, ventricular overdrive pacing, corrected BBI minus tachycardia cycle length. You have to consider the corrected the change in AH interval. If it's less than 110 millisecond, it is a case of AVRT. More than 110 millisecond, AVNRT. And to understand the concept, golden rule, when you assess boost pacing interval and ventricular overdrive pacing, you should take into account possibility of decremental conduction by overdrive pacing. It occurs in AV node, result in AH prolongation. So the difference between BPI minus tachycardia cycle length and AH interval on the first return beat minus interval during tachycardia, it's very important. So golden rule, if boost pacing interval minus tachycardia cycle length less than 115, it is a case of AVRT. If it is more than 115, you should assess AH interval. If the net value is less than 110, it is a case of AVRT. If the corrected BPI more than 110, it is an AVNRT. And this is a case of tachycardia, looks SVT now complex tachycardia 1:1. When we assess the difference between BPI minus tachycardia cycle length, it looks more than 115. It is like AVNRT at the first glance. However, if we measure the change in AH interval, the corrected BPI minus tachycardia cycle length is 105. So the corrected BPI less than 110, it is a case of accessory pathway. So extremely important to assess delta AH interval as in this case. Next, golden rule during ventricular overdrive pacing, difference between stem to A during pacing and VA interval during tachycardia. In AVRT, it is less than 85 millisecond. If more, it is AVNRT, and it is the same concept. AVRT, we are very close to the circuit that involves the ventricle, so the value is stem to A minus VA during tachycardia less than 85 millisecond. And this is a case of AVRT using accessory pathway. At the right side, the tachycardia assess VA time 210. It is a typical AVN. It is an accessory pathway, and stem to A during pacing 266. So the difference is less than 85. This is another example of AVRT, difference between stem to A during pacing 138 and VA during tachycardia 120. The net result is less than 85. So we are dealing with a case of accessory pathway. Let's go to next example. When we have to assess the transition zone in case of AVRT, when you start ventricular overdrive pacing. And in case of AVRT, we know very well it is a large re-entry using accessory pathway, and the AV node involve the ventricle, and we will start pacing from the RV. Let's assess when we will reach the atrial resetting. Is it early or late? It's very early, because once we start pacing from RV, the impulse will join the re-entry, then reach the atrium and start atrial resetting. So it is very early during transition zone. Number two, what about the morphology of QRS complex during AVRT? We can appreciate fusion of ventricular activation between the re-entry, antegrade impulse come from the re-entry, and the retrograde impulse come from the pacing. So we have an evidence of fusion between the tachycardia and the pacing. That's why it is a fused morphology, not based morphology. In AVNRT it's a different story. It's a based morphology, and the timing to atrial resetting is very late. Golden rule to discriminate AVRT from AVNRT: start ventricular overdrive basing, transition zone, timing to atrial resetting during entrainment. In case of AVRT, it's a very early atrial resetting, maybe during transition zone. In AVNRT, it's a different story. It's a late atrial resetting, and we reach the resetting after transitional zone and starting the based stable morphology. Next, golden rule: when we start overdrive basing, transition zone, assess morphology of stable based QRS complex. In AVRT, it is fused morphology, fusion between the tachycardia and the basing beats. However, in AVNRT, it is only based beat. Here there is an example when we start ventricular overdrive basing in AVRT. Look at ECG. Transition zone F1 to F4. Then last two beats we reach the based stable morphology. Great. So we have transition zone about 4 or 5 beats, and based morphology the last 2 beats. And we start ventricular basing at rate of 320, and let's see when we reach atrial resetting of same cycle length of the basing morphology and rate 320, we can appreciate atrial resetting in the second and the third beat of transition zone. So it is very early atrial resetting, confirming a case of AVRT. So atrial resetting stem 2A come in the transition zone. So let's assess the morphology when we have a case of AVRT. Start ventricular overdrive basing, stop basing, and see what happened after stopping the overdrive basing, and see the morphology during tachycardia. It is a case of septal accessory pathway AVRT. How we know? Post basing interval minus tachycardia cycle length less than 115. But I want to highlight the morphology. Look at the left panel. This is the morphology of overdrive basing. Next, then assess the middle panel morphology during tachycardia. Then assess morphology during basing only without overdrive basing. We can appreciate the QRS complex during overdrive basing is a fused morphology between tachycardia and ventricular basing. One more evidence of AVRT and accessory pathway mediated tachycardia. Next, golden rule: difference between HA interval during basing and HA interval during tachycardia. In AVNRT, it is more than minus 10, maybe 0, positive 10, 20, 40. But in AVRT, less than minus 10, maybe minus 20, minus 30, minus 40. And in this case, it's the AVRT. Let's see the difference between HA interval during tachycardia and during basing. We will find it is minus about minus 40, confirming it is AVRT. What about atrial overdrive basing? Golden rule: difference between AH interval during atrial overdrive basing and AH interval during tachycardia. In AVRT, less than 40, and this is a case of narrow complex tachycardia. Then we start atrial overdrive basing, and here we can appreciate the difference between AH interval during basing 450 and AH interval 325. It's a case of AVNRT more than 40. Let's go to the next advanced maneuver to discriminate AVRT from other SVT, and the concept of His synchronous BVC is extremely important. When we give ventricular extra stimulus in presence of accessory pathway and the impulse go retrograde to the atrium, but we don't know the retrograde conduction was nodal or accessory pathway. So let's give a ventricular extra stimulus at time the His bundle in refractoriness. So if the beat went retrograde to the atrium, it means it is accessory pathway conduction, confirming it is a case of AVRT. Amazing concept of His synchronous BVC. So let's see, let's give His synchronous BVC in case of AVRT. I will give it in time of His refractoriness. So the impulse will go retrograde, it will find the His blocked in refractoriness. So it is only one open pathway. It is the accessory pathway, and it reaches the atrium and lead to atrial pre-excitation, confirming presence of accessory pathway. Let's assess the response of his synchronous BVC in AVRT. We have three scenarios. First one, it will advance the A, pull back the A, confirm presence of accessory pathway, but we don't know about participation in tachycardia. Second scenario, termination of AVRT, a stop of tachycardia without A, confirm presence of accessory pathway and confirm participation in tachycardia. Last scenario, delay of next A, push the next A, confirm presence of accessory pathway, and it is decremental and participating in tachycardia. Let's see this example of a case of AVRT. Tachycardia cycle length at 280, and we decide to deliver his synchronous BVC at time of his refractoriness and assess the next A. What happened? It is advance the next A, it become 260. Then see next example again, we give his synchronous BVC, advance next A at 260. So it confirmed the presence of accessory pathway because of advancement of next A. No doubt about this. But is this accessory pathway participate in tachycardia or not? It all depends on resetting of tachycardia. If no resetting of tachycardia, it means there is accessory pathway does not participate on tachycardia. If there is advancement of A with resetting of tachycardia, it confirms presence of accessory pathway and participation in tachycardia. Back to our two examples, we give his synchronous BVC, advance next A. What about the subsequent A interval? Same cycle length of tachycardia, so it reset the tachycardia, participation of accessory pathway in tachycardia. But in this example, no atrial resetting, subsequent A interval 300, no atrial resetting, no participation in tachycardia. Let's go to the second scenario when we give his synchronous BVC during tachycardia, sudden termination of tachycardia without A. What does it mean? Confirmation of accessory pathway and participation in tachycardia. Last scenario, deliver his synchronous and delay of next A. It means presence of accessory pathway, participation in tachycardia, decremental conduction. So let's see an example to illustrate more the beneficial role of his synchronous BVC when we give his synchronous BVC at time of his during tachycardia, cycle length 432. Look at next A, what happened? Nothing. So this maneuver is invalid now. We give his synchronous late coupled BVC, however, of no value. Why? Next A, no advancement, no delayment, no termination of tachycardia. It is inconclusive. Let's repeat his synchronous BVC at time of his refractoriness. Look at next A. Yeah, there is advancement of next A, confirmation of AVRT, and the presence of accessory pathway. Why? Retrograde conduction was through the accessory pathway that pre-excite the next A. Let's go to this example. Give his synchronous BVC. Termination of tachycardia. Just a second. Termination V and A. It's of no value. We agreed before. It should be V without A. So this inconclusive maneuver of no value. Last example, his synchronous BVC. Termination of tachycardia V without A. Confirmation of AVRT and accessory pathway. And let's welcome our Professor William Miles, who give us the concept of his synchronous BVC, from which he measured the pre-excitation index. What is the pre-excitation index? Difference between tachycardia cycle length and ventricular extra stimulus with longest coupling interval that could pre-excite the atrium through the accessory pathway during tachycardia. So, if the pre-excitation index less than 110, confirm accessory pathway pre-exciting the atrium through the bypass tract, it is a case of AVRT. But if the index is more than 110, it means nodal conduction, AVNRT. And this is an example when we give his synchronous BVC and assess the difference between tachycardia cycle length 410 and the BVC with coupling interval 346. So the difference less than 100. It's a case of AVRT, accessory pathway. Let's go to next golden rule. When we use early coupled sensed, it is not late coupled. It is not his synchronous BVC. Early coupled BVC assess termination of tachycardia after the sensed BVC. If the SCVT terminated without A, it is likely to be AVRT and unlikely to be atrial tach. But if termination with A, all options are there. So this is a case of AVRT. Using an accessory pathway, we give early coupled sensed BVC, termination of tachycardia without a case of AVRT. It's a likely accessory pathway and the atrial tach is excluded from our list. Let's continue and jump to the third advanced special maneuver to differentiate nodal conduction from AVRT using septal accessory pathway. Differential RV basing. So we will put the RV catheter in the apex and start apical basing and measure the time, the interval, the impulse need to go retrograde from the ventricle to the atrium, stem to A. Then put the RV catheter at the base of the ventricle and start basal basing and assess the interval stem to A and see the difference. So golden rule in differential RV basing, you have to discriminate between nodal and extranodal conduction, AVNRT and accessory pathway tachycardia. Stem to A interval in differential RV basing. In case of septal accessory pathway, you will find stem to A interval is shorter during basal basing than apical basing because you are close to the septal accessory pathway. However, in nodal conduction and AVNRT, you will find the stem to A interval in apical basing is shorter than basal because you are very close to the His-Purkinje system. And this is the main concept in case of accessory pathway at the right side. Let's see stem to A. When you start basal basing, stem to A is shorter than stem to A during apical basing. Why? Because you are very close during basal basing from the accessory pathway. At the left side in nodal conduction, it's a different story. You will find the stem to A, the orange one, during apical basing is very shorter than stem to A during basal basing because you are very close to His-Purkinje system when you base from the apex. So let's an example of a case of accessory pathway. How we know? At the right side we start basal basing. How we know? From lead 2, it's a positive QRS complex. And let's start basal basing. Assess stem to A. It is 100 milliseconds. On the same case, we started apical basing. How we know? On the left side, because of negative QRS complex, stem to A become 140 milliseconds. So stem to A prolonged so much when we go to the apex. What does it mean? The septal accessory pathway. At the left side, stem to A 140 milliseconds because we are very far from the accessory pathway. And when we go very close to the accessory pathway, start basal basing, stem to A just 100 milliseconds. Let's make it all together in accessory pathway. Start basal basing, stem to A 100. We can appreciate it is very short interval. We are close from the accessory pathway when we base from base of the heart. However, in RV apical basing in presence of accessory pathway, we can appreciate stem to A become very long, 140 milliseconds. We are far from the accessory pathway. Let's go to next example. When we appreciate evidence of accessory pathway and we started to do differential RV basing. Let's see stem to A when we base from the apex at right side of the heart. Stem to A 160 milliseconds. We are far from the accessory pathway. On the left side, basing from base of the heart, stem to A very short, 44 milliseconds, because we are very close to accessory pathway. We confirm diagnosis and we did accessory pathway ablation, and we repeat the same maneuver to confirm is it successful accessory pathway ablation or not. So post ablation we start apical basing, stem to A 180 milliseconds, which prolonged so much to 188 milliseconds when we base from the base of the heart. What does it mean? Become nodal conduction, no evidence of accessory pathway conduction, successful accessory pathway conduction. Golden rule, you should use differential RV basing to discriminate septal accessory pathway from AV node. In septal accessory pathway, you will find shorter stem to A interval when you base from the base of the heart in comparison to apical basing. However, in AV node and AVNRT, it's a different story. Stem to A is shorter when you base from the RV catheter apex because you are close to His-Purkinje system. Let's go to the last basing maneuver, the His synchronous, the para-Hessian basing. what is the concept of para-Hessian basing and how it helps us and guide us discriminating nodal conduction in AVNRT and the septal conduction, extranodal conduction in AVRT. As we know, his bundle is deep structure and capsulated, surrounded with fibrous, and if you want to capture his, you should base very close to his, at base of the heart, using high output, may reach 15 or 20 to capture his of his bundle. Then retrograde conduction, AV node and the atrium. Once you base at low output, you will lose his capture and you will start a long way. RV depolarization, cell to cell conduction, right bundle, retrograde his bundle, his AV node, then atrium, and you will find white QRS complex because of cell to cell conduction. Stem 2A will increase in nodal conduction. This is the main concept, golden rule. Para-Hessian basing will discriminate nodal and extranodal conduction. When you lose his capture during para-Hessian basing, if it's AVRT, you will find stem to A interval fixed when you lose his capture. However, HA interval will decrease. In AVNRT, it's a different scenario. Stem to A interval will increase dramatically when you lose his capture. However, HA interval will be fixed because of nodal conduction. So let's go to this illustration. At right side, it's accessory pathway, and we start in orange the para-Hessian basing, high output, and the capture his. So stem to A is short. Retrograde conduction through the His and the AV node, also through the accessory pathway. Then let's base in low output, loss of his capture, it will be white QRS complex, and see stem to A almost the same because retrograde conduction through accessory pathway. So stem to A in accessory pathway is fixed when you lose his capture. However, on the left side in nodal conduction, it's a different story. When we start para-Hessian basing, capture the His, stem to A is very short because you capture the His successfully. But when we use low output, loss of his capture, this blue one, it will take longer trip, ventricular activation, reach tip of right bundle, then retrograde conduction, his Purkinje system, AV node, his and the atrium. So when you lose his capture, stem 2A will prolong so much and white QRS complex. So let's give an example. Para-Hessian basing in extranodal conduction, accessory pathway. We start para-Hessian basing in the first beat, then second beat show white QRS complex using low output. We lose his capture, so white QRS complex, and no change in atrial activation sequence. And the most important is stem 2A 95 millisecond, same when you capture the His. What does it mean? It is fixed retrograde conduction through the accessory pathway. What about HA interval? It decreased. And to understand this, at left side we start high output basing, para-Hessian basing, and retrograde conduction, accessory pathway, in addition to His capture and retrograde His and the AV node. Stem 2A 95 millisecond and HA 80 millisecond. On the right side, using low output, loss of his capture, white QRS complex. What happened? Retrograde conduction, accessory pathway. What about stem 2A? Same, 95 millisecond, but HA interval decreased because no nodal conduction. And to illustrate more, this is a case of accessory pathway, and came to our EB cath, and we decide to confirm the presence of accessory pathway. At left side, it is loss of His capture and RV capture only. At right side it is narrow complex His capture using high output. Stem 2A during His capture 44, and when we lose His capture it is also 44. So it is accessory pathway, and we decide to go for accessory pathway ablation, and we did accessory pathway, localized, ablate, and now we want to confirm is it successful or not successful. At the left side we decide to go for parahesian basing, first and second beat loss of His capture, third and fourth beat narrow complex His capture. Stem 2A during His capture was 134. Stem 2A during RV capture only and the loss of His slightly increased. It is not nodal capture at all, and it is not accessory pathway conduction, and we confirm successful accessory pathway. Stem 2A increased when we lose His capture dramatically. It means nodal conduction. Let's go to see how can we localize the accessory pathway using all diagnostic basing maneuver to know is it left or right accessory pathway, is it lateral or septal accessory pathway. So let's see how this basing maneuver not only confirm the presence of accessory pathway and telling it is a case of AVRT, but also it will help us to know where is the accessory pathway. As we know, as a golden rule, we know the localization of accessory pathway. Where does it locate? From the atrial activation sequence during tachycardia or ventricular basing, but also the advanced basing maneuver will help us with some tips and amazing tricks to know where is the accessory pathway. So let's see. In ventricular activation basing, see the accelerated atrial beats to know is it right or left accessory pathway. As we tell during overdrive basing, we have return zone, capture zone, transition zone, and this is the golden rule from we can tell much data and finding confirming the septal accessory pathway. But I want to highlight the number of resetting of atrial beats during or after transition zone. We know in AVRT the resetting is very early, and in AVNRT it is very late after transition zone. But I wanted to highlight during transition zone we know the resetting of atrial beat will tell it is AVRT. But let's see how many resetting of atrial beats. If we have 3 or more atrial beats, it is right lateral accessory pathway. If we have only 1 or 2 atrial beats resetted during transition zone, it is left lateral accessory pathway. And to see some examples to illustrate, it's a case of AVRT and atrial resetting in and during transition zone. But let's see how many beats of atrial resetting with fixed stem 2A. It's about 4 or 5 during the transition zone. What does it mean? We are dealing with right lateral accessory pathway. And in this another example of AVRT, we reached atrial resetting during transitional zone. However, we have only 2 beats of resetting atrial beats with fixed stem 2A, only 2 beats in transition zone. Yes, it is a case of AVRT, however it is left-sided. Now let's go to a next golden rule, how special maneuver help for localization. Go for corrected post-basing interval. Yes, we know from before post-pacing interval minus tachycardia cycle length, it is less than 115 in case of AVRT. But let's see the final value. In septal accessory pathway, it will be less than 115, obviously maybe 60 or 50. However, in lateral accessory pathway, is still less than 115, but slightly maybe 110, 18. And to understand the concept that we discussed before, in AVRT it's more than 115. In septal accessory pathway, we are very close, so the difference is less than 115, maybe 50 or 60. In AVRT using left lateral accessory pathway, it's a gray zone. Now let's go to corrected post-pacing interval. Golden rule in AVRT, it's less than 110. We know about this. Let's go to more details. In AVRT, using right lateral accessory pathway, the corrected BBI less than 55. If it's more than 55, it is left lateral accessory pathway, and this is the collection of ventricular overdrive pacing to tell where is the accessory pathway. Using corrected BBI less than 55, it is right sided. Or resetting of atrial beats more than 3 or 4 beats, it is right sided accessory pathway. Let's go to next maneuver using his synchronous BVC pre-excitation index to know is it septal or lateral accessory pathway. Golden rule, we know before, pre-excitation index in AVRT it's less than 100. Let's go to advanced golden rule in AVRT pre-excitation index. If it is less than 45, it is septal accessory pathway. By the way, the original paper by Professor Miles confirmed this finding. All septal accessory pathway less than 45. However, if it is more than 75, it means it is AVRT using left lateral accessory pathway, and we know the concept of his synchronous BVC, and this is the original paper by Dr. William Miles confirming septal accessory pathway pre-excitation index more than 45. And to understand the concept of this in AVRT, if we give his synchronous BVC, it will take time to reach the AVRT, and we have to see the difference between tachycardia cycle length and the BVC coupling interval. In AVRT it's early coupled BVC, that's why it will be more than 110. In septal accessory pathway, tachycardia cycle length is long involving the V, and if you want to give his synchronous BVC, it should be very late coupled to reach the AVRT using septal accessory pathway, so almost no difference between them. So tachycardia cycle length minus BVC coupling interval, it less than 45, it may be 20, 10, it may equal each other. If using left lateral accessory pathway, it's more than 75 milliseconds. Still using the advanced maneuver to know where is the accessory pathway, septal or lateral. We know about Comel sign, and we know that Comel sign show increase in VA interval during ipsilateral bundle branch block. In AVRT there is increase in VA interval, however in AVRT no increase at all. Let's go to more advanced golden rule. Yes, we know VA interval increase in AVRT, but if increase more than 35 milliseconds, it confirm lateral accessory pathway. If there is a slight increase about 20-25, it is septal accessory pathway, and we know about this in left lateral accessory pathway. If the patient developed left bundle branch block, it will be dramatic increase in VEA interval more than 30-35 milliseconds, confirming left lateral accessory pathway. And this is the example of narrow-complex tachycardia. AVRT, cycle length 290 on the right side. On the left side, the patient of accessory pathway developed the typical left bundle branch block. That's why cycle length dramatically increased and the VEA interval increased 30 milliseconds or more, confirming lateral accessory pathway, not septal. And this is the golden rule from Brunwald, and how Philip Kummel described in amazing way, still using the accessory, the basing maneuver to know. In case of orthodromic tachycardia, we may use some maneuvers to know in septal accessory pathway, is it right septal or left septal accessory pathway? We know it is septal accessory pathway and we know it is AVRT, but let's confirm, is it right septal or left septal? Amazing recommendation to know and differentiate right from left septal. A change in VEA interval during orthodromic reciprocating tachycardia between Hess catheter and the coronary sinus catheter, anterior catheter and posterior catheter. In case of right septal accessory pathway, the common septal, we will find a change in VEA interval less than 25. However, if it's a left septal accessory pathway, the change in VEA interval will be 25 milliseconds or more. Amazing golden rule to discriminate left from septal accessory pathway, and this is the useful explanation from Brunwald to tell us how to know all finding discriminating left and right posterior accessory pathway. And this is a summary of many basing maneuver helping to confirm AVRT and also to localize where is the accessory pathway using many special advanced maneuver localizing accessory pathway. It's our golden rule: 25, 35, 45, 55. Let's review all of them. 25, in case of we use the change in VEA interval discriminating left and right septal accessory pathway. 35, it helps us in common law to tell us is it lateral accessory pathway confirming AVRT or not. It change and increase in VEA interval when the patient developed ipsilateral bundle branch block. Then 45 in pre-excitation index. If the patient has pre-excitation index when use his synchronous BVC less than 100 is AVRT. Less than 45 it confirms AVRT using septal accessory pathway. And finally 55 in corrected post-basing interval minus tachycardia cycle length less than 55 confirm right side accessory pathway, more than 55 confirm left sided accessory pathway. And this is the whole summary from Brunwald textbook telling how to localize the accessory pathway using all advanced and simple basing maneuver. Now let's go to the final part in our presentation today, the most challenging scenarios, accessory pathway. how to ablate the accessory pathway. Really, it was challenging in diagnosis, induction, EB study, and now let's see how to ablate the accessory pathway. And we should know that we have to go first to map the accessory pathway, confirm the diagnosis, map where is the accessory pathway. Is it septal or lateral, anterior or posterior? Is it right-sided or left-sided? And I have to go to transseptal puncture. Then start ablation, and we should kill from the first time. You should know the successful endpoint. When we see you are in good place and you have to stop, and for sure you should avoid complication, especially with mid-septal and anteroseptal accessory pathway. Avoid heart block. Let's start mapping. And for sure, our main target of ablation is the accessory pathway itself, which go across the AV annulus, maybe mitral annulus or tricuspid annulus. So how can we map the accessory pathway? We have two approaches. First one, mapping the aorist V activation during antegrade conduction if the patient has manifest pre-excitation, maybe in sinus or atrial pacing. Second approach, mapping aorist atrial activation during retrograde conduction when the patient has tachycardia, AVRT, orthodromic tachycardia, or when we perform ventricular pacing. So assess during antegrade ventricular activation, retrograde atrial activation, and for sure during retrograde conduction, it's better to ablate accessory pathway during orthodromic tachycardia better than ventricular pacing, because if tachycardia terminated, it means the accessory pathway gone 100%, no retrograde conduction over the node. It's only accessory pathway. So let's go to earliest site of ventricular activation, antegrade conduction. There is manifest pre-excitation. We should have A and V, and it is highly appreciated if we see accessory pathway potential, and you should go for ideal place where you are early, you are ahead from ventricular activation and delta wave at ACG. The more earlier you are, the good accessory pathway and the outcome. So criteria of successful ablation site in antegrade mapping. What you should search for: presence of accessory pathway potential, local V, precede onset of delta wave, which is V delta, 30, 40, 5, 50 millisecond. Balance between A and V, it means you are at AV annulus. Short local AV, usually we use this with some exceptions like prior ablation. 5, negative QS morphology complex. When you use unipolar electrogram, it means you are in ideal place. Continuous electroactivity between A and V, and for sure stable catheter position. This we should know, and this is second approach. When we decide to map during retrograde activation, ideally try to map during orthodromic reciprocating tachycardia and see earliest retrograde A, and we know retrograde conduction through the accessory pathway, so we know the place and we can localize. And when you ablate during AVRT and terminate the tachycardia, what does it mean? Accessory pathway gone 100%. So what you should search for during retrograde conduction and activation: number 1, presence of accessory pathway potential. It makes sense. Earliest retrograde local A, short local VA interval, and you should search surface QRS complex to local A less than 70 millisecond in orthodromic. Local VA should be constant regarding direction of ventricular wavefront engaging the accessory pathway, continuous electrical activity between V and A, and finally stable catheter position. We know about this. And this, during ventricular pacing, we can assess airless retrograde A. We will localize where is the accessory pathway, then termination of conduction. And this is all collection from Brunwell to know how to map. Now, let's go to golden rule from Jackman, who is telling the most accurate place to ablate is accessory pathway potential. This is the most important, and you have to know, and you have to confirm and validate it is accessory pathway potential, not a component of A. It is not a part of A, not a part of V. So it is for recommendation. Employ decremental pacing until accessory pathway conduction block. Number 2, give atrial extra stimulus until accessory pathway reach ERB. Number 3, during AVRT, look for potential that is missing when AVRT terminates spontaneously to confirm it is accessory pathway potential. Finally, deliver atrial extra stimulus while you are delivering ventricular pacing to see if atrial extra stimulus can move the local atrial potential and dissociate from sharp potential to know is it really an accessory pathway potential or not. So let's see, we can appreciate atrial pacing, decremental pacing, and we can see there is a potential and the sudden it disappear during reaching accessory pathway block, conduction block. What does it mean? It means this potential during pacing is really an accessory pathway potential. Now let's go to next maneuver. Give atrial extra stimulus and see antegrade accessory pathway conduction. We can appreciate this one is accessory pathway potential that disappear after this because of reaching accessory pathway ERB. Now let's see AVRT. There is tachycardia in the beginning, and we can appreciate accessory pathway potential that disappear after termination of tachycardia. And finally, this is a case where we start ventricular pacing, then we decide to give atrial extra stimulus to discriminate is this accessory pathway potential or a part of A or V. Another golden rule from Jackman to tell us how can we discriminate AVNRT from AVRT. A little bit difficult, but let's try to understand. Deliver ventricular extra stimulus and check the aorist atrial activation sequence on proximal CS. Start, put your catheter at posturoseptal base of the heart and give ventricular extra stimulus and see can you advance V and maybe H to rule is it AVRT or not. This is from basal posturoseptal RV. Then go to basal anteroseptal RV and deliver ventricular extra stimulus to rule in AVNRT. If no advancement to V or H, it exclude accessory pathway and confirm it is AVNRT. And this is example when should you give extra stimulus from posturoseptal and anteroseptal to discriminate AVNRT and accessory pathway. Now let's start ablation, and you have to know amazing, highly recommended golden rules for creating effective lesions to eliminate accessory pathway 100%. Number 1, good mapping, accurate localization. You should be good mapper rather than aggressive ablator. Don't ablate everywhere. take your time, map more and more, localize accessory pathway. Then when pre-excitation is present, ablation can be performed during normal sinus rhythm if manifest pre-excitation or atrial pacing. In concealed accessory pathway, or if energy delivered during V pacing. And the most important golden rule, one shot, one kill. Try to get from the first time. Don't ablate more and more to avoid catheter-induced trauma. Ensure catheter stability. And if no response after few seconds, don't continue. You have to stop, map one more time, take your time, and then ablate. And this is an example where we did ablation after good mapping. Look at lead 1, evidence of pre-excitation, AGM short time interval, then sudden loss of pre-excitation, and AV time increased. Another example, but in this we should illustrate a common mistake. The catheter is not stable. Don't ablate here. How do you know? Because A and V amplitude is changing and changing and changing. What does it mean? Your catheter is not stable. Don't ablate. And here we can appreciate failed site of ablation, left side, and successful site of accessory pathway ablation. What is the clue? Look at unipolar ablation catheter, where we can see QS morphology, negative morphology. It means you are in good place. That's why successful site. Now let's go to golden rule. When we have a right septal accessory pathway, it's posterior septal, we know, and it's very common to go from the right side. But in case you did 1-2 trials of ablation for right posterior septal accessory pathway and failed, it's still there, evidence of pre-excitation. What is the next step? You have to think in 3 steps. You should go for the non-coronary cusp or left-sided anteroseptal accessory pathway or left-sided mid-septal accessory pathway. This is very common scenario when you failed to ablate the posterior septal accessory pathway from the right side. And to imagine more and more, let's see this illustration where you can appreciate this is the right side accessory pathway, looks mid-septal in this, but you are afraid because you are very close to AV node. You failed to ablate. So we can think in different way in this right mid-septal accessory pathway. Go to non-coronary cusp or right coronary cusp. You can go to the left side mid-septal anteroseptal to avoid AV block. Great. Let's go to next golden rule. What are the successful endpoint of accessory pathway? So I know the accessory pathway, localized, good mapping, I ablated. What are the successful endpoint? Confirmation, loss of antegrade conduction, and sure, confirmation, loss of accessory pathway, retrograde conduction. If it is antegrade conduction, confirm antegrade block. How I know? Lack of pre-excitation, sudden loss of pre-excitation, and the AV interval will prolong. Amazing illustration. Loss of pre-excitation in ECG lead 1, and the AV interval increased. It was fused in the first and the second beats at ablation catheter. Then it's loss of pre-excitation. Now let's go to retrograde block to see the successful endpoint. Concentric activation rather than eccentric. It will be decremental conduction, consistent with VA conduction. Nodal conduction may be dissociated, and the VA interval will increase so much. Finally, in case of anterior and mid-septal accessory pathway, you can use cryoablation. And thank you so much for this illustration and attendance.